All right, so starting by the first question, are you able to identify the impressions on the spleen for me? Can you identify A again?
It's a renal impression.
Okay, what about B?
It's a splenic flexure impression for splenic flexure of a large colon.
What about C?
It's a gastric impression.
And D?
It's a hilum of the spleen.
Okay, I think you've done very well in A, B, and C, and D, I think, in the pancreatic tail or the tail of the pancreas. But otherwise, you've done very well. All right, so A is renal impression, and B is the, like I said, the splenic flexure for the colon, and C is the fundus of the stomach or the stomach. And yeah, well done. All right, so let me just make sure that everybody's in now. Okay. So great. So can you tell me the blood supply of the spleen?
Yes, the blood supply is mainly through the splenic artery, which is a branch of the celiac trunk. And venous drainage is from splenic vein, uh, which drains into superior, which drains combines with superior mesenteric vein to form the portal vein.
All right, well done. So I'm glad that you divided into arterial and venous, and the arterial is splenic artery, and venous is the splenic vein to form superior vena, superior mesenteric vein. All right. So what are the related ribs to the spleen?
Uh, the spleen is related with the 9th, 10th, and 11th rib.
Well done. Structures to worry about while you're doing a splenectomy.
Tail of pancreas.
Okay, excellent. So remember, we talked about D, which is literally in the hilum, very close to the hilum, the tail of the pancreas. Well done. Structures, yeah, we said that. And the course of the splenic artery. What is the course of the splenic artery?
So, splenic artery originates from the celiac trunk in the midline in front of the abdominal aorta, and then it runs towards the left on the upper border of the pancreas and passes behind the stomach and reaches the splenic hilum and supplies to the spleen, pancreas, and the fundus of the stomach.
All right, well done. So it arises from the celiac trunk, upper border of the pancreas, and then into the renal ligament and terminal branches on the hilum. And yeah, you mentioned even more details. Okay, great. So the question is the spleen normally palpable in your examination?
No, sir, it's not
Okay.
normally palpable.
When will it start to be palpable?
Um, if it's more than 5 centimeter, then we can palpate it.
Well, to be more specific, it's not 5 centimeter. To be more specific, when it's double its size, when it's twice as much
Okay.
as its normal size, you will be able to palpate it. All right. In supine position, what part of the abdomen is the most dependent?
Hepato renal pouch.
What do you
Space,
call it?
sorry,
Is there any
hepatorenal
other name
space.
for it? Is there any other name for it that you know?
Um, Sorry, sir, I don't know.
That's right. Morrison's pouch, but you said it correctly. Yes, it's a
Okay.
hepatorenal, and this is a continuation of the right paracolic gutter. What is its significance? Why is it important to know about?
Sir, because in when there is a fluid um, accumulation there, then when the patient lies down, that is the place where the fluid will accumulate,
Okay,
most of
that
the
is
fluid.
correct. Yeah, very well. So the fluid or might accumulate in this area and even lead to formation of an abscess. Okay, so it's very important to know about. It's site for collection of blood or pus in this area, and this might lead to formation of an abscess. Okay. So during midline laparotomy, can you take me through the layers that we cut in a midline laparotomy?
Skin, subcutaneous tissue, um, linea alba, and rectus abdominis. Sorry, rectus abdominis is not in the midline. Uh, and transversalis fascia, and then peritoneum.
Right, a few things to add, but well done. You've mentioned all of them apart from the corpus fascia. But yeah, well done. And obviously, the rectus abdominis muscle is not one of them. We're talking about the midline laparotomy, not the para midline laparotomy. All right. So I was thinking we might move to someone else now, and we can come back to you later as well, Saniha. Is that all right with you?
Okay, no problem.
Yeah. Okay. So who's next, guys? I think Nazir is next.
Yes, doctor.
All right. So Nazir, is there any preference, or do you want me to cover anything randomly?
As you wish, but the last time the mock, I did one station head and neck and one abdomen.
Okay. So shall we do the same this time as well?
Okay, no problem.
Okay. So starting with the pancreas, can you tell me the parts of the pancreas?
The pancreas is divided into the head, the body, and the tail, and the uncinate process.
Okay. What about the neck?
Yeah, so the head, neck,
That's
and
right.
body, and uncinate process. I'm sorry.
Yeah. Well done. And the tail as well. Okay. Can you tell me the cell groups in the pancreas?
Yeah, the pancreas is divided into exocrine and endocrine, so that the endocrine part releases the alpha cells, which release the glucagon, the beta cells, which release the insulin, and the delta cells, which release the somatostatin cells.
Right. Well done. The blood supply of the pancreas.
Yes, there's an arterial and venous. The arterial blood supply, it comes from the splenic artery, from the celiac trunk,
Mhm.
and the superior and the inferior pancreatic duodenal artery.
Yeah.
This is the arterial supply. The venous supply, it is it comes. I don't remember the venous blood supply.
Well, generally, the venous will always follow the arterial, so
Yeah,
it's sort of the
yeah.
same. So
Because
you have here the superior pancreatic duodenal artery,
from
and the gastroduodenal, yeah, and the inferior pancreatic duodenal artery, and the pancreatic branches from splenic artery. But I think that this question is meant to be arterial supply rather than, yeah. So sorry about that.
No
So
worries.
how many ducts that you know in the pancreas?
There is, I think the pancreatic. Do you mean the papillae,
Ducts in the
major,
pancreas. Do you know any ducts in the pancreas?
the main exocrine duct?
Yeah. So what do you call these ducts? Do you have like, okay, that's fine. I'm not sure if the question is clear enough, but we do have two ducts in the pancreas, the main pancreatic duct and the accessory pancreatic duct. All right. So the main pancreatic duct, it drains the
Major
head of the
duodenal.
pancreas, yeah, the neck and body and tail, through the major duodenal papilla, which is 10 centimeter from the pyloric, from the pylorus, and it opens in the posteromedial part of the duodenum. That's the major duodenal papilla. And this develops embryologically from the duodenum, something called the dorsal bud of the duodenum. Okay, so this is the main pancreatic duct. The accessory duct, which only drains the uncinate process and enter the duodenum through the minor duodenal papilla, and it develops from the ventral bud of the hepatic diverticulum. All right. So that's the difference between them. Okay. Can you tell me about the vessels that will be encountered during a Whipple procedure?
Yes, it will be the superior mesenteric artery and superior mesenteric vein, and also the splenic vein and the left renal vein, and the aorta.
Yeah, well done. So the
Yeah.
way I think about it, we're doing Whipple procedure, and this is mainly pancreatic duodenectomy, right? So you're removing pancreas and part of the duodenum as well. So I'm thinking about the aorta, which you give superior mesenteric artery, and you have pancreatic duodenal artery as well, which is superior and inferior. The inferior is coming from this. So basically, the very three are arteries, and they are literally aorta gives SMA, and then SMA gives the pancreatic duodenal artery, which is the inferior part. All right, and then on the other side you have SMV, splenic vein and portal vein. You know the answer now. They form each other, right? So SMV and the splenic vein, they will give you the portal vein. And then you have the renal vein in addition to it, the left side, okay? So this is the way to easily remember it. Okay, can you tell me the ligaments that are connecting to the spleen or connected to the spleen?
Yeah, there's the linear ligament, which is connecting the spleen with the kidneys.
Yeah.
And there's also with the stomach another ligament.
So yes, I think it's mainly the linear ligament. I know there is something else, but I think they are looking to here for linear ligaments. Yeah, it's fine. The embryological development of the pancreas. Do you know anything about it? So I think we literally said it before. So it's basically the ventral bud, which will form, and the dorsal
part from the dorsal aspect of the duodenum.
Yeah, and that will form this, and that will form this, and we know the ducts how they will form. Okay. Finally, can I identify number 3 in this image?
3, it will be the head of the pancreas.
What about 9?
9 is the body of the pancreas.
And what? I think that's it. But I mean, just maybe from the last time. What about 14?
14, it will be the inferior mesenteric vein.
Is it a vein or an artery?
An artery.
Yeah.
But it's not clear.
So obviously this is the neck of the pancreas. There are 2 veins, a vein and an artery that goes around there.
Yeah, so it's yes. This is 15 is the vein, superior mesenteric vein, and 14 superior mesenteric artery.
Excellent, well done. And when you look here, it has some branches on the other side. So obviously 7 it will be the middle colic artery, the right colic artery, and to give the other side that's usual branches and so on. All right.
Okay.
Sounds good. But the main thing that you need to know is head of pancreas and the neck of pancreas from there on. All right. So we can cover the liver quickly as well, and then we're going to go to the next person. All right. So can you identify from A to D? What is A?
A, it is the right lobe of the liver.
What about B?
B, the left lobe of the liver.
C?
C, it is the quadrate lobe.
D?
D, it is the caudate lobe.
F?
F, it is, I think, the inferior vena cava.
Well done. E?
E, we said it is the quadrate lobe.
No, we said C. Well,
yes.
We didn't say E.
Gallbladder.
Yeah, now it makes sense, right?
Yeah.
Okay, what about G?
G, it is the falciform ligament.
What about H?
It is the ligamentum teres, foramen ligamentum teres.
Okay, well done. What about I?
I think the bile duct.
K?
Okay, it is the hepatic artery.
J?
Portal vein.
Yeah, I think you smashed that. That's very, very good. So I think you said everything correctly, but apart from you confused caudate and quadrate lobe. So I think this is quadrate lobe D and caudate lobe C, but otherwise you covered everything very well.
Okay.
All right. So I think this is a very similar image. We're not going to go through it. It's literally the same thing. So, but just very quickly, what do you think of 23?
23, it is the hepatic artery.
No, look at the bigger image. So 23 is there and there as well. So and there as well. So 3 marks for just 23.
Hepatic ducts.
No. Okay. What do you think of 11?
11, it would be the hepatic artery.
What about 20?
20 is the portal vein.
What about 5?
5, the hepatic ducts.
Okay, well done. What about 16?
16 is the ligamentum venosum.
Okay, what about that? That's what's meant by 23.
Yeah, I don't know.
Porta hepatis?
Porta hepatis.
So we're looking at the porta hepatis for those 3 structures, and this is porta hepatis, all right?
Yeah.
I think that's the only difference between this one and the previous one. Okay, but otherwise it's the same answers really. Great. I mean, very quickly, Nazir, what separates the right and left lobe of the liver?
There are 2 landmarks. There is anatomically and surgical.
Okay.
Anatomically, it will be the ligamentum teres and the ligamentum venosum, fissure for ligamentum venosum.
Yeah.
While surgically, it will be a line which is drawn from the fossa of the gallbladder to the inferior vena cava.
Okay, well done. So anatomical and functional or surgical, and like you said, yeah, well done. Boundaries of the quadrate loop.
Boundaries of the quadrate loop. I'm always confused between the quadrate and the caudate, so I think this will be. I don't remember.
So if you look at this image, so 21 is quadrate loop, all right? So what are the boundaries? So you have on
Gallbladder
the gallbladder that is lateral or right or left?
to be right.
Right, gallbladder. What about the left?
Left falciform ligament.
Yeah, or fissure for ligamentum
Teres.
teres. Yeah. What about superior?
Superior porta hepatis.
Porta hepatis inferior.
Uh,
That's the inferior border of the liver. All right.
border of the liver.
Yeah. So quadrate is very beside the gallbladder. I'm not sure if we mistook it like here. So C, again, C is the quadrate and D is the caudate. I'm not sure if yeah. So C is the quadrate and D is the caudate lobe as well. All right.
Okay.
So the one beside the gallbladder is the quadrate lobe. Okay. Well done. We talked about the boundaries, structures of the porta hepatis. You just mentioned them. We're not going to go through them again.
Yes.
Two structures to be affected in a stab for the epigastric region.
It will be the stomach and the left lobe of the liver.
Okay. Blood supply of the liver. Just enumerate them.
Yeah, the arterial, we said arterial will be from the hepatic artery, and the venous will be the portal vein.
Okay. Well, to be honest, I wouldn't classify it arterial and venous. I would just say hepatic artery is 25%, because actually the portal vein is not venous supply, it's sort of arterial supply. It's a vein, I get it, but 75% of the blood supply to the liver comes from the portal vein. Okay. And it's a partially deoxygenated, but it's still sort of oxygenated and carries lots of the nutrients from the liver. And the venous drainage goes to the inferior vena cava. So just don't classify it to venous and arterial. You can do that, but when you say arterial supply, just meant a portal vein in that. Okay, because portal vein gives the liver like 75% of its supply. Okay.
Okay.
Ligaments supporting the liver. Enumeration.
I think this is a triangular ligament.
Yeah.
And the falciform ligament.
Okay.
And the ligamentum teres.
Okay. Anything else?
A ligamentum venosum.
Anything else?
And the lesser omentum, but it's not be mentioned the ligament, but it will be.
Yeah, true. It's one of the support for the ligaments for the liver, and also you can mention the coronary ligaments as well. So you mentioned triangular ligament. You can mention upper and lower coronary ligament as well, and teres and venosum together, and also the omentum and the falciform ligament as well. All right. What is Pelou triangle or callus triangle?
Callus triangle, I think it will be I don't remember. I'm sorry.
It's okay. So callus triangle, it's a triangle that is bounded by three structures. All right. So I'm not really sure if we're going to have a better image in here for that. So looking, actually, let's look at this diagram. It's going to come later on, but callus triangle, the liver will be there. So superior, the lower border of the liver, inferior will be the cystic duct, infralateral, and there is an artery coming in here, which is the hepatic artery, will be sort of medial. All right. So this is a triangle in here, or you can actually name it the common hepatic duct is medial. There is the importance of this callus triangle or Pelou triangle is very important for identifying the cystic artery, which is the blood supply for this area, the cystic duct. Okay. So because I mean, you need to, before you do the cholecystectomy, to identify the artery first, and close this artery, and before doing any sort of resection for the gallbladder. So the boundaries, it's bounded by the cystic duct, hepatic artery, and lower border of the liver, like we mentioned, and it does contain the cystic artery, mainly the cystic artery, right hepatic artery as well, and the right branch of portal vein. So it helps you. It's very important to help you identify all these structures before you move on with your surgery. Okay?
Okay.
All right, Nazir, is it clear?
Yeah, yeah.
Okay. So what is the epiploic foramen? Do you know anything about it? Or foramen of Winslow?
No, because there's a lot of questions I didn't see in the notes that I'm studying, so this is the first time I see it. Yeah.
Yeah, it's fine, no problem. So foramen of Winslow or epiploic foramen, it's literally the entrance to actually I can start drawing it to you. So basically, so if this is the lower end of the liver, for example, and this is the first part of the duodenum, and then you have the stomach going up there, right?
Yeah.
And this is the lower end of the liver. So the liver is here, and this is the first part of the duodenum. You have the lesser omentum. Obviously, the lesser omentum will come from here, and it will be attached to the porta hepatis, right? Like we said earlier. So it will be going up like that. So behind the lesser omentum is a lesser sac. Okay, and all the way around in the abdomen is the greater sac. So the foramen of Winslow is just right there. It's a foramen right there. Okay, that goes behind, it's the entrance to the lesser sac, basically. Okay, so so it's the connection between the lesser sac and the greater sac. These are not the question one or to define it. Okay, so it's asking you what is that foramen. So you just need to say it's the entrance for the lesser sac and it connects between the greater sac and the lesser sac. Okay, it's bounded by, in terms of boundaries. So we talked here that it does have anterior, so it's obviously the free border of the lesser omentum, right? And inferior will be the first part of the duodenum, this one, and superior will be the inferior border of the liver, and posterior will be the inferior vena cava, will be on the back. Okay, posterior inferior vena cava. Okay, so it's still very relevant and very important surgically as well. The free border of the lesser omentum, remember that area that we draw in here, that small area. If you open it and look inside, you will find that it has a few important structure, which is the portal triad. What is the portal triad? It will have the cystic duct and the portal vein and the hepatic artery as well. It will have three structures, very important structures. All right. And now we will know the surgical importance for it. So it has portal vein, common bile duct, and hepatic artery. All of them are on the free border of the lesser omentum. Let me just bring that back on and try to annotate it again. So again, we said it's the entrance for the lesser sac. It's bounded by these structures. We talked about caudate lobe and the free border of lesser omentum and first part of the inferior vena cava. And also, the free border contains portal vein, common bile duct, and also the artery. Well, if you're gonna forget this one, just say the inferior border of the liver. Yeah, great. So why is this important? Do you remember anything about it, Nazir, or would you like me to answer this?
Yeah. This is the Pringles maneuver.
Excellent. Well
in
done.
case it's a severe bleeding.
Yeah, excellent. So it's very surgically important. So when you squeeze it, it's a Pringles maneuver. And if the patient has sort of laceration of the liver and there is active bleeding, you can stop the bleeding by this maneuver. All right. So what are the structures that are squeezed? We mentioned the three structures, if you remember those structures, the portal triad.
The hepatic artery and the common bile duct and portal vein.
Yeah, exactly. These are the structures that will be squeezed. The last one, and we mentioned what is used for, it's control hemorrhage and liver laceration. All right. Thank you, Nazir, for your time. I'm gonna move on to whoever is next. Who's next, guys? It's in the chat, in the group chat. Whoever is next, please open your mic and comment. Who's next? All right, I'm gonna call a name now. So we had Nazir. Mohit, is Mohit here? Okay, we don't have Mohit. Bahar Sharma.
Yeah, I'm there.
Okay, excellent. So, Bart, we're going to start with you as well. Do you have any preference before we start? What would you like to cover today?
No,
No
you can go
preference.
to end. No.
Okay, sounds really good. I think because I mean, some people mentioned it's better to stay to one branch at a time. So we're going to continue with the trunk and thorax for now. So in terms of gallbladder, can you tell me what is the surface marking for the gallbladder?
9 costal cartilage and lateral border of the rectus muscle.
Okay, that's well done. So it's the lateral border of rectus muscle, ninth costal cartilage. Why cholecystitis cause some sort of pain in the shoulder?
Because they share the same nerves of the shoulder and the share the same nerve supply. Uh, that's why uh, they had referred pain.
Yeah, it's not really clear what you're trying to say. So why do you have pain in the shoulder? You said something about the nerve supply. What is the nerve supply that you know of?
It is called referred pain and uh, C3 and C4, I guess.
Okay, that's fine. So the diaphragm, I think this answer is wrong. You need to probably revise it. So the diaphragm is supplied by the phrenic nerve, okay? And the inflamed gallbladder will lead to irritation of the diaphragm, and this will go to the nerve roots of the phrenic nerve. And the phrenic nerve and the supraclavicular nerve do have the same origin, which is C3, 4, and 5, okay? So that's why the supraclavicular nerve will be share some pain, or called the referred pain, like you said, and it will cause some sort of shoulder pain. But it starts by the diaphragm is supplied by the phrenic nerve. Gallbladder inflammation will lead to irritation of the diaphragm, and the pain will be referred to C345, which is still the origin of supraclavicular nerve. Okay, so let's come to this nice diagram. So you have here, I think I'll probably get the image a little bit smaller for you, just to be able to see everything. Okay, so we have here, what is this study?
This is T-tube cholangiogram.
Can you say again?
T-tube cholangiogram.
It is sort of a cholangiogram, but what type of cholangiogram it is? Because
T-tube.
T-tube, there isn't a T-tube in there. There is no T-tube in there.
Then ERCP. I don't know.
Yeah, this is an ERCP. So cholangiogram is very non-specific answer. So you need to specify. So this is an endoscopic retrograde cholangiopancreatography. So because cholangiogram, you have an MRCP, which is a cholangiogram. You have a T-tube cholangiogram. You have an intraoperative cholangiogram. Many different things. Okay. So this is an ERCP. So can you tell me what is A?
A is ampulla of water.
Okay, well done. What is B?
B is the main pancreatic duct.
What is C?
C is common bile duct.
Okay, what is D?
D is fundus of the gallbladder.
Okay, what is E?
Body of the gallbladder.
And F?
Infundibulum of the gallbladder.
G?
Cystic duct.
H?
Common hepatic duct.
I?
Right hepatic duct, and J is left hepatic duct.
I, which is right and which is left? I
is left hepatic duct, and J is right hepatic duct.
Right hepatic duct. Well done. I think you got all of them correctly. Well done. Very impressed. Where does the common bile duct enter the bowel?
On the second part of the duodenum.
Which part specifically?
Second part of the duodenum, on the posterior medial side.
Okay, and how far is it from the pylorus? 10 centimeter from the pylorus. We said this early today. So 10 centimeter from the pylorus in the posteromedial wall of the second part of the duodenum through the major duodenum papilla. Okay. What is the anatomical structure that controls the secretion of bile into the duodenum? We're talking about anatomical structure.
Ampulla of water.
Well, the ampulla, it's sort of correct. It's really the sphincter of Uri, not the ampulla of Vata.
Spencer or Puri.
Yeah.
Okay, fine.
Yeah, the sphincter of Uri is what controls that. Okay. So next. So here I really need some quick answers for the following. So are you able to identify number 6?
It is a fundus of the stomach,
Number 2,
body of the stomach,
18,
antrum of the stomach,
19,
pylorus of the stomach.
and 23.
It is the first part of the duodenum.
Well done. We're not going to go through it. It's very easy. Parts of the stomach. What are the parts of the stomach that you know of?
Cardia, then fundus, body, antrum, and pylorus.
Okay, well done. The blood supply of the stomach. I need a very quick arterial supply. A very quick answer for that. For arterial supply.
So there is left and right gastric artery, left and right gastroepiploic artery, and short branches of spleen artery.
Well done.
Short gastric artery from spleen artery.
That's very sharp and great. I like it. The venous drainage will just follow it. We're not going to talk through it. And portal vein, splenic vein, splenomesenteric vein. That's fine. So I think we're going to give you the duodenum as well, and then we're going to move to the next person. All right. So duodenum. Can you tell me the peritoneal covering of the duodenum?
It's a retroperitoneal covered except the first part of the duodenum and at the duodenal junction flexion.
Okay, so all are retroperitoneal except the first part, which is completely covered by the peritoneum. Okay. What is the blood supply of the duodenum?
Gastroduodenal artery.
Is that it?
Gastroduodenal artery and yeah, I can't remember the other one.
So you have a gastroduodenal artery and a supraduodenal artery. And where do they arise from?
From the gastroduodenal artery arises from common hepatic artery, which is a branch of celiac trunk, while supraduodenal artery also arises from gastroduodenal artery.
Well, yeah. So to be honest, I mean, let me explain this to you a little bit on this side. So when you have the sort of the, so let's say if this is the stomach, like that. Okay. So if this is the stomach here, and you have here obviously the celiac trunk, it will give loads of branches. So you have here the splenic branch will go like that, just behind the stomach, and you have the hepatic artery coming here, the common hepatic artery, then hepatic artery proper going up, and then the gastroduodenal artery will go from here, right? So the gastroduodenal artery will give a supraduodenal branch. So this is called a supraduodenal. So that obviously will give the pancreas, all right? And then we'll go behind, the duodenum, and then we'll go behind the first part of the duodenum, and we'll give 2 superior pancreaticoduodenal branches. One is the superior anterior pancreaticoduodenal, like that, and one is the superior posterior pancreaticoduodenal artery. So if you look at those, so all of them, they do have duodenal in them. So supraduodenal, superior anterior pancreaticoduodenal, superior posterior pancreaticoduodenal, or let's say the superior pancreaticoduodenal. And then on the other side, when the aorta, let's say the aorta is going all the way down like that, you have here the superior mesenteric artery, which will give a branch called the inferior pancreaticoduodenal artery. And then again, the inferior will give an anterior branch and a posterior branch. So you have here down there an inferior, anterior inferior pancreaticoduodenal artery and posterior inferior pancreaticoduodenal artery. So when I ask you about the blood supply of the duodenum, it's supraduodenal, which arises from gastroduodenal, and the superior pancreaticoduodenal, which arises from gastroduodenal, and the inferior pancreaticoduodenal, which arises from the superior mesenteric artery. So these are the blood supply for the duodenum. Venous drainage will be literally the same, and it will go into the superior mesenteric vein and portal vein. Is it clear? Do you have any questions?
No.
Okay. The relations of different parts, to be honest, it's a quite complex area that I would like to skip. It's very important to study, but I think you can do that in your own time. There is no need to say the whole thing. It's very confusing and it's going to confuse lots of people, but you can study that in your own time. All right. We talked about the major duodenal papilla before, and we know that it's conical in shape and 8 to 10 centimeter distal to the pylorus. We talked about this, and it open in the junction of pancreatic duct and the common bile duct, which is basically the sphincter of Ori. So we talked about this like 2 times so far. All right. So thank you very much. I think I'm gonna move on now to the next candidate. And again, guys, so for the first 3 that we've seen, if we have time at the end, we're gonna come back to you and ask you again further questions. All right. So next, Jeffrey. Is Jeffrey here? Okay.
Yes.
Jeffrey, are you here? So Hill, are you able to close your mic, please? Turn off your
Yes,
mic, please.
I
That's right.
can.
Can you turn off your mic?
Yes.
I'm gonna mute you. So who's next, guys? I want the next person. I can't hear you. All right. So we have 3 people next: Jeffrey and Mani Kanta and Muhammad Muntasir. Do you have any of those? Okay, that is fine. Is there anyone else who is an observer and want to participate now? Otherwise, I'm gonna go back to the 4 that we have interviewed. Anybody else who is an observer and want to participate, please let me know. Anybody else who's an observer and want to participate, guys, please let me know in the chat. Okay, so Saniha, we're gonna restart with you until anybody decide if they want to participate. Saniha, do you want to open your mic again?
Yes, sir.
Yeah, thank you. So Saniha, we're gonna talk about the appendix now. Can you tell me the positions that you know for the appendix?
Yes, sir. The most common position is retrocecal, and the second most is pelvic, and the others are post-ileal, pre-ileal, and sacral.
All right, sounds good. So you have a retrocecal at the commonest, and subcecal, pelvic, pre-ileal, post-ileal are the common positions. What is the blood supply for the appendix?
The blood supply is the appendicular artery, which is a branch of ileocholic artery, which is a branch of superior mesenteric artery, and the venous drainage is from appendicular vein, which is a branch of superior mesenteric vein.
Well done. It's not a branch; it drains into the superior mesenteric vein.
Sorry. Yeah.
Yeah.
Sorry.
Why is the pain of is referred to the umbilicus at the beginning? Or to rephrase it, why there is shifting, the pain will shift to the right iliac fossa after having it in the umbilicus.
Yeah, so initially the pain from acute appendicitis, uh, it is a visceral pain, so it transmits its pain to the spinal cord via T10 nerve, which is also a dermatome for umbilicus. That's why it refers to umbilicus. But later on in chronic cases, the inflamed appendix irritates the peritoneum, and it causes the localization of the pain in right iliac fossa.
Okay, so very good. You explained it very well. I think the key words in here, you have visceral pain and parietal pain. So the visceral pain is conveyed via T10 fibers, and T10 is basically around the umbilicus. All right, and parietal pain, which happens due to irritation, is obviously would be where the collection are. All right, so the collection will be in the right inferior fossa. The pain will be in the right inferior fossa. Okay, well done. All right. So we have a few more things to cover. So your renal bladder. Can you tell me the blood supply of the renal bladder?
The urinary bladder is supplied by superior and inferior vesicular artery, which is a branch of internal iliac arteries, and the venous drainage is by vesical venous plexus, which drains into internal iliac vein.
Okay, well done. Let me just do this very quickly. Okay. The nerve supply of the trunnion muscle.
The sympathetic supply.
There is an echo with your voice. Are you able to sort it out, please? Hello?
Yeah.
There was an echo with your voice, but it's sorted now. So yeah, can you tell me the nerve supply of the trunnion muscle?
The sympathetic nerve supply, sir, I don't know about the root
It's
value,
all right.
but
No
it
worries.
inhibits the contraction of
Yeah.
the bladder that time. Yeah.
The sympathetic is L1-2, and it inhibits the contraction of the bladder wall and contract the sphincter. Parasympathetic contracts the bladder wall and relax the sphincter. Okay. Do you know any cancer types in the urinary bladder?
Yes, transitional cell carcinoma, squamous cell carcinoma, adenocarcinoma, mixed carcinoma.
Okay. Common presentation of urinary bladder cancer. What is the commonest one?
Painless hematuria.
Painless hematuria. Risk factors of bladder cancer that you know of?
Smoking, aniline dye, beta-nephthalin, and one more was there.
That's fine. You've said very well, but schistosomiasis might be one as well, and aniline dye is one, and smoking is very important to mention, to be honest. Ureteric orifices. Do you know where does the ureteric orifice, the ureter enter the bladder?
Yeah, at the base of the bladder, near the trigone.
Okay, at the corner, yeah. So the bladder at the corner of the trigone. The peritoneal covering of the bladder that you know?
The peritoneum covers the superior surface and the upper surface of the posterior, upper part of the posterior surface.
Okay. So that is, yeah, very good. Suprapubic catheterization. Do you know the layers for that?
Yeah, skin, scarpa's fascia, linea alba, transversalis fascia, and peritoneum.
Okay. Do you remember that this is literally the same for the midline
Yeah, same as the
laparotomy?
laparoscopic. Yeah.
Yeah, laparotomy. Okay. What I mean, forget about the posterior relation. It's just retrovesical pouch and uterine pouch. Let's identify some important structures in here. Let me just get it a little bit closer for you to be able to see everything. Okay. So can you say what is number 7? What is that?
Ovary.
Ovary. Okay. What is number 8?
Fallopian tube.
What is number 15? You know, it's pointing down there, just behind the uterus.
Yeah, it's rectovesical pouch.
Okay. And what is number 18?
18 is urinary bladder.
Okay. So well done. I think you prepared very well. So ovary is number 7 and 8 is the fallopian tubes, and the the number 15. To be honest, I think there are some mistakes in here. I need to correct it, but it's related to the numbers really. Yeah, obviously it's here. So 18 is bladder, and the other one is the vesicle. The retrovesical pouch. Rectouterine pouch. Sorry about that. I mean, mind the numbers. It needs to be corrected, but it's as you said. Okay. Looking at this one, can you identify number 2?
Sir, I'm not able to see where is number 2.
I'm pointing to it by my mark. Can you see my
Oh,
mark?
sorry. Yeah, it's appendix.
Okay. And what is number 4?
It's cecum.
What is 15?
Ileum.
Okay. Yeah. So again, I mean the numbers just changes when I do that, but so 2, 4 is cecum and 15 is the terminal ileum, right? Right. I think that's enough with the trunk and thorax, and we need to spice it up with a few more things. Maybe head and neck. Is there any, Saniha, are you happy to continue with head and neck, or you said you're not really with head and neck, right?
Yes, sir.
So just out of fairness, do you feel that's enough for you, or do you want one more station?
Sir, if you continue with upper limb, I won't mind.
Okay. So it's because I want to leave the upper limb for just one session, upper limb and lower limb. So we need to get done with the head and neck and the trunk and thorax. I can give you one more trunk and thorax if you would like.
Okay, sir.
That's fine. So let me spice it up by this one. So what are the site for chest tube insertion?
Sir, it is in the safe triangle,
Where is that?
triangle of safety. The borders of triangle of safety are anteriorly the posterior border of the pectoralis major, posteriorly by the anterior border of latissimus dorsi, and um, inferiorly by the imaginary line passing through the fifth intercostal space.
Okay. So Sania, I think you know it very well, but have you ever inserted a chest drain before, or seen it being inserted?
No, sir.
Okay, that's fine. So when a chest drain is being inserted, to be honest, a surgeon will not really care about the pectoralis major and these lines, or the boundaries of the safe triangle. All what they're looking for is the mid axillary line, fifth intercostal space, all right, and the nipple line as well.
Sir.
So they will go and find where the nipple is and go in line with it to find the fifth intercostal space, and they will go in the mid axillary line. So that's the fifth intercostal space, and then they will insert it here. So I think what they're willing to hear is fifth intercostal space, mid axillary line. That's the first thing that they want to hear. And then you would like to say the boundaries, like you said it. It's absolutely fine. You can say the boundaries. But again, the boundary doesn't have to be very anatomical. You don't have to mention latissimus dorsi and pectoralis major. I mean, like literally just mention the lines. They're interested for you to know where are the things rather than knowing the absolute anatomy forever. Anyways, what are the layers of a chest drain go through during insertion?
Skin, subcutaneous fascia, intercostal muscles, and intercostal space, and then a pleura of the lung, and between the parietal and visceral layer of the pleura.
Okay. So I'm pretty sure that you started everything very well, but probably this question you didn't read before. So it's skin, subcutaneous fascia, and then deep fascia, and then serratus anterior muscle. The intercostal muscles would be external intercostal muscle, internal intercostal muscle, and innermost intercostal muscle. And then you have the endothoracic fascia, and then top parietal pleura. So when you think about it rationally now, after we said that, so you have from the outside, starting by the skin, subcutaneous fascia, deep fascia, they come together. And then three layers, three muscular layer, and then which is basic, four muscular layer, which includes serratus anterior and the external, internal, innermost intercostal, and then endothoracic fascia, which is the fascia that lines all the thorax from the inside, and then the parietal pleura. All right. So these are the structures that we need to go through. Okay. Well, the patient developed bradycardia following a chest drain insertion. Can you explain this to me? What could be the reason?
Because the stimulation of the vagus nerve.
Okay, so stimulation of the vagus nerve, which is bradycardia. Okay. Let me